Tennis elbow, also known as lateral epicondylitis, is a very common cause of elbow pain. It can be a very frustrating condition for patients who are frequently expecting a more ominous diagnosis because of the severity of their pain and who can't understand why it takes so long to resolve, even with appropriate treatment. Let's take a look at the anatomy. The elbow joint is formed where the forearm bones, the radius and ulna, meet the distal humerus. The lateral epicondyle is the small bony protrusion on the side that provides an attachment point for the extensor muscles of the forearm that come together to form the common extensor tendon. The most important extensor tendon in a conversation about tennis elbow is the extensor carpi radialis brevis, as it is the most commonly involved. Also commonly involved is the extensor digitorum communis. The extensors span the forearm from the lateral epicondyle to their respective insertion points. In the case of the extensor carpi radialis brevis, the insertion point is the second and third metacarpal bones of the hand. As the extensors contract, they pull the hand back toward the elbow, a movement referred to as wrist extension. Tennis elbow has traditionally been treated as an inflammatory condition. After all, the word epicondylitis means inflammation of the epicondyle. In inflammatory conditions, the body reacts to injury or infection by releasing inflammatory cells and mediators of inflammation, which results in pain and swelling. However, there are few inflammatory cells present in the tendon tissue during tennis elbow. Instead, tennis elbow appears to be an angiofibroblastic tendinosis. Simply put, the normal healthy tissue of the extensor tendons is replaced with degenerative tissue. Tennis elbow is diagnosed clinically. Findings include tenderness at the lateral epicondyle and common extensor tendon, and pain at the elbow with resisted extension of the wrist. Pain may also be present with passive wrist flexion with the elbow fully extended. X-rays are helpful for ruling out other causes of wrist pain, but no abnormal X-ray findings are present in tennis elbow. There may be some signal uptake into the extensor carpi radialis brevis on an MRI representing tendinosis. However, an MRI is rarely necessary unless the diagnosis is unclear or surgery is being considered. Treatment for tennis elbow has traditionally focused on relieving inflammation. Ice and non-steroidal anti-inflammatory drugs like ibuprofen are frequently recommended. Steroid injections provide a more potent and direct anti-inflammatory benefit and are usually injected with a local anesthetic such as lidocaine that provides nearly immediate but only temporary relief. Anti-inflammatory treatments may provide some relief, but as we talked about earlier, tennis elbow is really a condition of unhealthy tissue as opposed to inflammation. Other treatment options include counterforce bracing, such as a tennis elbow strap. The idea is that the muscle begins to pull from where the strap is placed instead of from the common extensor tendon at the lateral epicondyle. This may give the tendon a chance to heal. Activity modification is also important. Strenuous, especially repetitive extension of the wrist and hand is avoided if possible. Physical therapy can also be beneficial. Controlled eccentric exercises of the extensor muscles stimulate healing. Soft tissue mobilization by way of the Graston technique is thought to debride the unhealthy tissue and stimulate growth of more healthy, robust tissue. Ayano Phoresis is the use of an electric charge to drive steroids or non-steroidal anti-inflammatories through the skin to the injured tendon. No matter the treatment, tennis elbow often takes several months to resolve. Patients frequently become frustrated when their condition does not seem to be improving after several weeks. If symptoms do not improve after 6 to 12 months of conservative treatment, more invasive treatments may be considered. These include PRP injections and autologous blood injections, in which platelet-rich plasma, or the patient's blood, is injected at the site of the tendinosis to stimulate healing. Percutaneous needle tenotomy involves breaking up the pathologic tendon tissue with a needle to stimulate the growth of healthier tissue. More aggressive debridement can be performed surgically. The bottom line: tennis elbow is tendinosis of the extensor tendons, especially the extensor carpi radialis brevis, near their origin at the lateral epicondyle. There are no X-ray findings associated with tennis elbow, and the diagnosis is based on symptoms and physical exam findings. Initial treatment includes NSAIDs, bracing, ice, activity modification, and physical therapy. Steroid injections are sometimes given to relieve pain, but are not shown to be effective in the long run. In the uncommon incidence of recalcitrant tennis elbow that does not improve after 6 months to 1 year, PRP injections, needle tenotomy, or surgical debridement may be considered.